Hello, and welcome to the presentation on my evidence-based proposal presented by Jessica Stanley. The topic we will be discussing today is whether or not medication-assisted therapy reduces the risk for relapse in the population of opioid-dependent pregnant women who are being treated with medication-assisted therapy. Medication-assisted treatment is an evidence-based program that treats substance use disorders, and it includes the use of medications such as methadone or sometimes naltrexone and buprenorphine. These are given to people who suffer with substance use disorder, but we are mainly discussing the effects in the pregnant women population. Over the past 15 years, the prevalence of opioid use disorder among pregnant women has increased a substantial 333% based on a study done by Kranz et al. Although medication-assisted treatment used during pregnancy has increased substantially, there are still gaps present between treatment and education. And the significance of this literature review is that the opioid use epidemic is a crisis situation that is only going to get worse. Evidence-based education must be available to combat the issue, especially within the pregnant population. When pregnant women are using opioids, the fetus is affected as well as the mother, and by abruptly discontinuing the use of opioids during pregnancy, the result can be premature labor, fetal distress, and miscarriages, according to Substance Abuse and Mental Health Services. The significance of this literature is that opioid use disorder is a family disease that affects the sufferer, the unborn fetus, families, and societies at large. However, stopping illicit drug use during pregnancy without proper medical treatment is proven to be dangerous and can be fatal. Substance Abuse Mental Health Substance Act is a public health issue, and pregnant women with opioid use disorder must be given evidence-based knowledge. Medication-assisted treatment is recommended instead of abstinence or withdrawal because pregnant women who stop using opioids and relapse are at a greater risk for overdose deaths. The significance of this is that medication-assisted treatment versus opioid withdrawal during pregnancy can have better outcomes for reducing the risk of relapse postpartum for the mother. Medications used in MAT are individualized and are typically comprised of methadone or buprenorphine, also known as Suboxone. These medications are meant to prevent opioid withdrawals and reduce opioid cravings. By preventing adverse effects of discontinuing opioids, pregnant women have a greater chance of success in the future. And this is definitely significant in the fact that pregnant women who experience less unpleasant withdrawal symptoms while receiving MAT have a greater chance of reducing the risk for relapse due to reduced opioid cravings, according to the literature review that I have been completing. Khan et al. Conducted a pilot study that asked if parenting education groups for women in treatment with OUD in the outpatient setting elicits positive patient feedback. The results of this research study show that patient focus groups and the participants responded positively to the educational support groups, indicating that they found the educational content useful. Although the pilot study is preclinical research, it does show promise to positive effectiveness of educational programs to women with OUD who are pregnant on medication-assisted therapy, and it is useful in shaping the MAT educational evidence-based proposal. Wilder et al. Conducted a non-experimental retrospective cohort study in which the question asked is, what is the association of methadone dose with substance use and treatment retention in pregnant and postpartum women with OUD? Now, the results of this study are extremely useful in that the linear models of data analysis showed significant positive relationships between the dose the women were receiving and treatment retention at delivery and at 60 days postpartum, as well as a significant positive relationship between length of time in treatment and treatment retention at delivery and at 60 days postpartum. Based on this study, women on medication-assisted therapy, specifically methadone, statistically have a higher likelihood of remaining free from illicit drug use with a methadone dose over 60 milligrams versus a dose that is lower than 60 milligrams. And this information would be noteworthy to implement in an educational program to pregnant women with OUD, and also to give this information to providers in this field of practice. The proposed intervention would be based off the Iowa model, and the goal is to create and implement an educational program for participants to identify whether MAT in pregnant women with opioid use disorder reduces the risk for relapse. The problem is opioid addiction in pregnant women. And that leads to the clinical question, which is for opioid-dependent pregnant women being treated with MAT, does the use of MAT reduce the risk of relapse? The plan is to form a team of medicine, addiction experts, psychiatry, pediatricians, nursing, and pharmacy to review the most current up-to-date evidence. The design plan is going to include sampling, methods, subject recruitment, demographics, and informed consent. Evaluation would be done by clinically appraising quality and relevance of the evidence that was collected and determine the applicability in this study. We would synthesize the findings to support the evidence to conduct the project. And ultimately, the end goal is to design and pilot a practice change, namely implementing an educational program for pregnant women with OUD on MAT. Intended change integrates into practice by monitoring key indicators by quality improvement. This follows a systematic approach by identifying a clinical problem, conducting a literature review, and determining the best intervention and monitoring the results in a systematic way. This will ultimately lead to better patient outcomes and will ensure successful implementation of an educational program for pregnant women addicted to opioids. The proposed project methodology includes the population of opioid-dependent pregnant women who are receiving medication-assisted treatment. The sample size is determined by how many volunteers attend the scheduled program for 1 hour per week for 52 weeks, based on informed consent and on a voluntary basis. Inclusion criteria includes women aged 18 to 35 with documented opioid use disorder history. They must be receiving MAT as a treatment, and they must continue MAT postpartum. They must participate in the educational program intervention and must be in a self-help group for additional support. Exclusion criteria includes actively using illicit substances, including alcohol, an inability or unwillingness to participate in self-help groups. The recipients must be in the outpatient setting and cannot be inpatient or in a treatment center. And lastly, exclusion criteria includes the unwillingness to participate in the educational program intervention. The setting will be a private conference room in one large outpatient clinic in the Northeast that provides medication-assisted therapy to pregnant women. Data will be collected using the Time to Relapse questionnaire that was originally initiated by Edenhoff et al. In 2005. The useful topics will be collected as data for topics for discussion, and participants will receive the questionnaire pre- and post-intervention. Urine drug screens will be given weekly, and data will be gathered in the program via voice recordings anonymously, and questionnaires will be analyzed, and the data will then be synthesized. Outcome measures will be determined by graphs and charts, and they will be used to determine if the educational program reduced the risk for relapse for pregnant women on MAT. There are ethical considerations, including that we are treating a scientifically complex population, and informed consent is essential. There must also be permission by the IRB and clinic as necessary. This topic has significance in nursing because opioid use disorder is an epidemic, especially in pregnant women. Patient education will build strong patient outcomes, and nurses and healthcare providers are a patient's first line of defense for obtaining pertinent knowledge about their disease, namely the disease of addiction in this case. By providing evidence-based educational programs to pregnant women with OUD while receiving MAT, their risk for relapse may be reduced. Lastly, participants in the program may learn coping tools to enhance their self-help support groups. This lends to innovation because developing an educational program for women with OUD on MAT to participate in during and postpartum is essential to develop new knowledge in nursing practice. This will transform patient care by implementing immediate solutions to immediate problems at hand that patients are currently facing, therefore improving the delivery of healthcare and improving patient outcomes in pregnant women with opioid use disorder on MAT. I thank you for taking the time to listen to my presentation in full, and thank you again.